Good afternoon to our viewers on Facebook, and I'm Mark O'Donnell. I'm Chief Executive of Royal Blind and Scottish War Blinded, and it's a great pleasure to welcome Professor Jason Leitch, the National Clinical Director for the Scottish Government, who's very kindly agreed to come and answer some questions that we have gathered in from our community. So Jason, hello and warm welcome.
Hi Mark, nice to see you again. It's a pleasure to be here. Thank you for asking me. Not
at all, we're very grateful. You and I had the pleasure of working together a number of years ago, and I'm very conscious from first-hand experience that your professional career has been predicated on keeping people safe in normal circumstances in health and social care, and very much as well around putting people at the centre of their care. So it's been no surprise that those issues have been at the fore of all of the high-profile work that you've been doing since the pandemic started, and I'm sure we'll capture those themes today. Just to manage expectations of our viewers, they shouldn't be expecting a kind of Piers Morgan style grilling from me. I'm sure I would be quickly put back in my box with great skill. But with a serious note, what we do have is some very important questions. As I said, that we've been asking our community of people with visual impairment to send us their thoughts in terms of things we might want to ask you. So we'll try to group those up into some important themes, and we'll launch in if that's okay with you, Jason.
Of course, of course.
The first theme is around care homes, obviously a very big topic in the current circumstances, and thinking particularly around the two specialist care homes that Royal Blind runs for people with visual impairment, the only ones actually in Scotland. So as you can imagine, we've had a lot of interest from families, including from Connor, David and Rosie, about when they might be able to visit their loved ones as we ease out of lockdown. And understandably, they feel that contact's important for the well-being of their family members. But of course, we all know the importance of protecting them from the virus. So the question, Jason, is, do you have any thoughts on when visits might be possible and how they could happen?
It's a great question to start with, but a really difficult one to be too precise about. In my defence, I'm the guy who wrote the letter that abolished visiting across all of our health services. So visiting is really close to my heart. I was really proud when the NHS in Scotland became the first national system to abolish visiting in every setting. I was then also the guy that had to write the letter to say we're abolishing most forms of visiting for coronavirus. It broke my heart to have to do it. But you're right, it's a balance between harms. So and right now, and hopefully not too much longer, the principal harm we're trying to prevent is harm from the virus. Now, we know that's not without cost. We're not stupid enough to think that thing is the only harm here. We've got people waiting for procedures, we've got people not able to see their families, people not able to see their loved ones, and we've got people with mental health challenges or dementia or other things cooped up in rooms or houses or care homes where normally they would have communal activity and be able to be much more socially enabled. So I'm hoping that we'll be able to do that as soon as possible. Remember, there are some exceptions to the visiting rules. You can visit if your relative would be distressed by you not visiting. So if you have a relative who is learning disabled or a relative who has severe dementia and they would become really disorientated by not being part of you or not seeing you more often, that is an exception, as is end-of-life care. Now, we don't define what that end-of-life care means. That would be something you would discuss with the care team and your family about who that would be. And we're not suggesting a family of 8 should go with flasks of coffee. We're suggesting that should be done in a very common sense way so that people can still stay connected. I hope that when the numbers get low enough of the virus in circulation, that we will be able to slowly release those visiting restrictions, but it won't be sudden and it won't be tomorrow.
Okay, thank you. That's very helpful, and I'm sure that will be of great interest to the questioners and to wider population. Just moving on to activities for people in care settings, and specifically we've had a question from Colette about the guidelines for residential care for younger people. Royal Blind runs services for younger people with visual impairment as well. question is, how can we ensure that the guidelines are specific to younger people with care needs so that they can take part in activities suitable for them? And we've also had related questions about how we can safely ensure people who are in residential care settings, young or old, can keep active.
Yeah, it's again an excellent question. The fundamental public health advice, whatever your age, is that to prevent the transmission of this particular virus at this particular point in the pandemic, and we have to keep saying that. So this is the third week in May. We need to be very careful that this is the third week in May advice. So as we learn more, as we perhaps get treatments or even vaccines, or the virus changes its behavior, things will change. Just now, and at this phase of the response, we're asking people not to do communal activities within close proximity. So we're asking people in care homes and settings where people reside, that could be children's homes, it could be prisons, where to not do communally things, to not do communal behavior. That again is heartbreaking. That's not what we want to do. If you are having to come out of rooms and do that, you need to try and keep 2 meters apart if you can. Remember, this virus spreads in droplets from person to person or surface to person. So anything you can do to interrupt that transmission. So that's cleaning down the surfaces, that's cough etiquette, that's trying to stay apart from people so the droplets don't spread from person to person. Now, of course, there are settings where that's impossible. That will be impossible in some settings with young people. It will be impossible in some places with very young children or those who require personal assistance to help and support them in some way. We fully recognise that 2 meters is not possible in every individual setting. But at a population level, when we give the whole population advice, that's what we're trying to do. We're trying to keep everybody safe. Now, organisations such as yours, Mark, I think have to help us with the translation of that into your context. So you and your stakeholder group, your circle of influence, they understand your particular needs best, and we can help with that. We can do the generic level, but you, I think, have to help us, as other third sector organisations do, with what that means for your particular interest group.
Okay, no, I welcome that. I think that's right, specifically around visual impairment. There are lots of challenges around that and subtleties around the way that people with sight loss need to navigate, and trail, which is, having to touch things, whether or not they have a cane,
Yep.
And obviously the risk that brings. So we'd be very happy to use our community to try and make sure that the guidance is apt for those people. Just sticking with
maybe some Warblind branded alcohol gel that you could clip to your waist. I can imagine a world in which
branding opportunity.
So yeah, there's lots of alcohol gel opportunities for loads of people. So we were just talking to Transport Scotland yesterday about all the bus drivers having alcohol gel available to them in their cabs, train drivers, train conductors. So each sector is having to think a little bit about what this new world will look like. And I don't think this sector, forgive me for the shorthand, but I don't think this sector is any different from that. We've got to adapt to what's going to keep you safe and your family safe.
That's right, and I think it's about trying to support the development of the guidance as much as possible, as it's being shaped. I know that's very challenging at the speed that you're having to move at, but making sure that these things are thought of up front and the impact on these disadvantaged groups is in there. So
yep.
We're happy to help with that. If I can just stick with care home environments for a bit, we'll move on to some wider themes shortly. We've also had a number of questions about around testing and ensuring that care home staff are being tested for coronavirus. And Pauline and Evelyn have asked whether staff and carers should not be tested on a regular basis. And we've also had a question from Donald related to that on whether there could be weekly updates on the number of residents and staff who have tested positive.
So the first part of that is yes, we're going to test staff and carers in care homes regularly. I think it's important, let's put testing in perspective since we're dealing with an intelligent group of individuals. So the present test that is presently available in the world looks for the genetic material of the virus. It finds that genetic material of the virus just before you get symptoms, while you have severe symptoms, and then tails off as you recover. So the test is not perfect. it gets everybody who has the virus pretty much. It gets about 100% of them, 90 something percent of them. But it doesn't get everybody infectious. It gives you false positives, so it often finds virus where you're no longer infectious. So we don't want all the care home workers at home if they're not infecting people, and we don't want suddenly all the staff to have to self-isolate and the whole country to go back in the house. So we have to be slightly careful that we believe testing alone is going to solve this problem. I'm not diminishing the role of testing. It's absolutely crucial, but we have to do it wisely and at the right point in the process. The other thing about the test is it is not very nice. So if you are a frail, elderly person with dementia, or you're a child, actually, even if you're an adult, it's not nice. It's a cotton bud up your nose, almost in your brain, and right down the back of your throat. It is an unpleasant test, and people underestimate what that means in a care home of 65 people with dementia and a host of carers around them. So that doesn't mean we shouldn't do it if it's required, but it's not quite as simple as maybe the red top newspaper was had to believe. Let's just test the whole population. We'll know on a Tuesday if everybody's got it and all will be fine. So we've got to do it if we need to answer a question. So clinicians only use tests if there's a question to answer, and if that question will then allow us to do something different. So testing for a chest x-ray or testing for a biopsy always is in service of a clinical question. And testing for coronavirus should be the same. It should be about, are we going to isolate these people? Are we going to treat these people? What's the plan? Why are we testing? And then, of course, we should then test in the correct environment. We do publish test numbers. We publish test numbers and positives, negatives. It's not enormously helpful to the population to have those numbers, but we publish them every day.
Okay. And just a brief follow-up on staff in care settings who are shielding. Morag, our Head of Care for Older People Services in Royal Blind, has asked, has any decision been made about those staff in the longer term and how we address that?
So let's remember what shielding is. A little bit of confusion sometimes between shielding and high risk. Shielding is a very elite group, 170,000 odd people in Scotland. You don't want to be in the shielded group. Shielding is horrible. Shielding is a letter that told you basically to stay at home for 3 months. It's pretty horrific. And we're having to put in place food parcels and medicines delivery. And so I'm astonished anybody wants to be in that group, actually. And people are asking to be put in it. It is not a good group to be in. We only put you in it if you're at such high risk of the virus that we think that is worth it. And that's a clinical decision. People who have had bone marrow transplants, people who have had solid organ transplants, people who are undergoing some forms of aggressive chemotherapy, not people who happen to have COPD or happen to have diabetes. It's a high-end group. The group below them, the increased risk group, which would include my parents, my mum with COPD, some of my other relatives, they're the ones who are asking to be very careful about social contact, very careful when they go out, but can go out for exercise, for essential purposes. But we're asking them to be really, really careful. The shielded group, the present shielding advice finishes in the middle of June, and we're in the process now of meeting as clinical groups and support groups with local authorities and others, thinking about what we're going to do to that group as we begin to release some of the lockdown measures. I don't know what that will end up looking like, but I know that it won't be back to normal. It may not be quite as severe as it is now, but it will not be completely back to normal immediately.
Okay, thank you very much. And talking about social distancing, we have a particular question from a young person with visual impairment. The Royal Blind runs the National School for Children with Visual Impairment, but there are also 4,500 children with visual impairment out there in mainstream schools. So the question from Summer is that as a visually impaired student going back to school, how would they be able to social distance safely?
Yeah, it's a really, really tough one. And I don't think we know the answer, Summer, yet. I know that social distancing is a relative thing. So there are some settings in which you simply can't do it. So let's take an extreme version of that. If you're in a nursery, an early years setting, and you're looking after the babies, then clearly it's ridiculous to socially distance. But if you're in a 5th year higher class for English, then we should be able to set that class up in the main to be able to be socially distanced, you would think. It may be a little bit difficult with transitioning in and out the room and things like that. But so at two extremes, I think we know what to do. I think in between those two extremes, we're going to have to make some compromises. We're going to have to talk to the community. So Summer will help us with that. It will be easier, perhaps, if you use the same person all the time. I realize you wouldn't always be able to have a family member with you, but it might be simpler and easier in a risk-based way if we just use Frank rather than Frank and 25 others to do that. So I think there are ways we're going to have to think through that with organizations such as yours. I was asked exactly the same question by the BBC, who have a number of disability correspondents who go out into the world, and they work on disability stories, and they're often accompanied by a producer. And that producer would be their personal assistant as well as their producer. So we're going to have to think through what the guidance will be for that. Remember, anytime you leave your house just now with this virus is risky. So the only non-risk thing to do is to stay at home. However, as we begin to think about what that looks like, we're letting people go to ASDA already. We've been letting people go to ASDA for 4 months. That is risk. So each step is well judged, but increases risk in the population. So we're not going to tell Summer to stay at home longer than her pals because she's visually impaired. That would be immoral. But we're going to have to think with Summer what it means for her to be as low risk as she can when she re-enters that society with her mates. And I don't think that's impossible. I think we're able to do that. But it may be that Summer has to take a little bit more risk than her best friend. That may be an inevitable consequence of this virus.
Flowing from that, perhaps then, there's a question around vulnerable groups more generally. And we've had some questions from Mike and Aidan and Monty around this. And they've been asking why people with visual impairment weren't defined as being a vulnerable group. And that, as a result, that has led to some problems with, for example, accessing online shopping from supermarkets. So the question they've got is, wouldn't it have been preferable if they had been deemed vulnerable from the outset, because that would have helped?
Yeah, so the clinical choice at the beginning for the likes of me, the advisors, the clinical choices at the beginning were those who are at risk of dying from the virus. And visual impairment does not make you die of the virus. What makes you die of the virus is immune disorders. So chemotherapy, heart transplants, things that affect your immunity. So that's who we added to the shielded group. And then that's also who we added to the highly vulnerable group, those who get the flu vaccine, those who are over 70, that group, who we set in place pretty quickly, actually, a local authority support system. Your correspondent is correct, though. The support system in there for online shopping for other hasn't been quite as slick as we would have liked. It's got a lot better. And most people have family, friends, and neighbors who will help them out, but not everybody does. And we're very conscious that not everybody lives in a community where that is all accessible. And I've seen a lot of subsector organizations, faith groups, others step forward to help in communities like that to try and provide some of that support that's required. But the straight answer to the vulnerability question was the vulnerable groups, rightly, I think, are those who are at risk of the virus, not who necessarily just need more support for living, which I think we can do more of, but is a slightly separate question.
Okay. And again, flowing from that, there's been some questions around accessible communications for people with visual impairment, which is something, again, that we're happy to help with and have done, actually. Royal Blend runs the Scottish Braille Press, which produces accessible formats of different kinds for people with visual impairment. The question that we've had, or as an observation, at least from Ken, around frustration that when the First Minister's letter to all households on the pandemic went out, it wasn't available online quickly afterwards for people with visual impairment who use online technology to access it. And a related observation around the daily press conferences, which obviously you've participated in, showing, for example, visuals and graphs, and very important ways of explaining what's happening and what we're trying to do, the flattening of the curve and so forth, which clearly blind and partially sighted people can't see. So Ken's question really is, how can we ensure important information like this is accessible for them?
Yeah, so I'm going to sound a little bit defensive first off, and then I'm actually going to take his point because he's right. But my defensiveness up front is I think he's confusing the Scottish briefings with the UK briefing. So we haven't shown graphs. The UK briefing has shown graphs. The Scottish briefing hasn't. Though I shouldn't use that defense, because I have been asking to use graphs in the Scottish briefing because I think they're quite helpful. But you're absolutely right. They have to be done as accessibly as we can, and we should have that information in forms that can be used by everybody. We've used signers, the UK government hasn't. So everybody's got a slightly different version of accessibility. I think we should make those elements of our communication as accessible as possible. I'll check the letter. That's a very interesting observation. I thought that our official correspondence, such as that, or if we make a big change to the guidance like we did yesterday about the new symptom that we're adding, I thought that letter was translated into all the standard languages that we use and into accessible format so that people could do it. I'll check that as soon as we stop talking, Mark. I think that was, and if not, I will correct that just as soon as I can. There is in our defense, he says defensively again, in our defense, I have never known information and marketing and communication to move at this pace ever in my life. I mean, this virus is 150 days old. I feel as though I've been at this for 4 years. We've only been at it since February. So much of what we're doing is really quick. That's not an excuse, and we should absolutely take on board what your organization and others are saying, and you can help us with that. And I remember the first time I realized it's a different community, but the first time I did a little video for a community, I got into trouble for it not being subtitled. Somebody taught me how to subtitle on an app. We've now got captions on those little videos. But it's fast, it's really fast moving. So we need your help with that. We need to understand how to do it and how to do it quickly. And I think our official stuff is pretty good at that. Our slightly more ad hoc, when I decide to speak to the autism community because the autism community asks for something, that probably not quite as accessible as it could be. And your colleagues and supporters would be helpful in that space, I think.
That's helpful. In fairness to you, I could have trailed the question with recognising, just the pace at which things are moving and how that's unprecedented.
Yeah, but that's no excuse. We shouldn't just go quick for people who can see, should we?
No, absolutely. And I guess that would be my bookend. That of course we have to do everything we can to make sure that we live and learn together, and our organisation and others, will definitely be looking to support that going forward. We've got a theme on mental health, and it is Mental Health Week, as you will know. And we know that many people with visual impairment need support for their emotional well-being as a result of their sight loss under normal circumstances, and clearly be made more difficult for them to get that support in recent times. So Kieran has asked, how can we be sure that the support and services will be there to meet the increased need for emotional support that there will be, particularly for blind and partially sighted people as we come out of lockdown?
Yeah, I think this is a crucial area. I am not sure I can be sure. Was it Kieran? I'm not sure I can be completely sure. I can tell you that we are endeavouring to do what Kieran asks. I could list a set of millions of investment and people who have been in the jobs. So that is all true. We have invested heavily. We've set up new helplines. There's a lot more online resource in Breathing Space, in Young Scot, in other places. That resource, I think, is now good and in a good place. I do worry about a backlog that we've stored up because the health service has not been working at full pace, inevitably, because it's getting ready for this infection. So I can tell you that remobilization is being planned now. So I've had conversations today about how we restart some hospital-based services, both in mental health and in elective surgical care. And the organizations who run mental health inside the health boards and with the integrated joint boards are ramping that up, are thinking about how that happens, just like we're doing dentistry and optometry and everywhere else. And that will have to take account of what that backlog looks like. I worry, I honestly do, I worry about the cooked up demand, not just of chronic mental health, but mental health challenges that we've created by what we've done for good reason. But I worry a bit about what will happen when we ask people to go back to work and we ask people to re-engage with society. That does worry me. Kieran is right. And I can tell you that people are very alert to it, and we'll do our absolute best.
Absolutely, yeah, and I concur with that anxiety, the impact that people will have and feel for some considerable time. And then circling back for the last kind of set question, back to social care, but thinking about care services at home this time, as there are many people living with sight loss who rely on care services at home. And Dawn has asked us specifically if you can tell us, Jason, how blind and partially sighted people who receive that support can be assured that staff will have the right personal protective equipment and obviously minimise the risk of infection, particularly by being supported by the same carers regularly.
Yeah, so the PPE thing, I think I can now put to rest and say that is available and people know how to access it. And some of that was a little bit challenging with supply chains and we're not done. There's still a lot of work behind the scenes about making sure Scotland is in the right supply chains, but the whole world is after that. So I'm pretty confident now. I'm not hearing many stories of PPE struggling to get to the front line or carers or others not getting it. Unpaid carers can now access the hotline and the email address and get supplies. So I'm pretty confident that bit is there. I think our second point is really, really interesting. So it's a bit like our personal assistant point. So minimizing risk by minimizing the number of people. It's a bit like creating your family bubble, your household bubble. And in some countries, they've expanded that household bubble so you're allowed slightly more people. We haven't done that yet, but we may in the future. So I think there is something about the way we design the care system so that it's not new people every day. And the care sector is seriously thinking about that and how we can make that happen. So I think it's an excellent point, and I'll reinforce it with my colleagues.
Much appreciated. I think that I've covered most of the questions. We did have a question from Jamie and Jimmy, which I didn't ask, but I think because it was around encouraging people with sight loss to get out and about and be active, and the question of sighted guides, I think you pretty much covered that earlier in your answer more generally about that. So hopefully nobody will send me across email that I haven't asked a question. I just wondered if there was anything else that you hoped that I would ask, any final points around guidance or advice you wanted to give?
No, I would ask the community to stay engaged as much as they possibly can, either through the third sector organisations such as yours or individually. I think local communities have stepped up to help one another, and this community is no different. It both helps and needs help, but it's not a one-way street. It's not a pedestrian community looking for everybody to support it. I completely understand there's so much for your community to offer in this pandemic as well as receive. And I think it's really important that the communities of practice, whatever they are, whoever they are, feel supported, but also feel able to help others. So you have neighbours, you have friends, you have grannies and grandpas and kids, and you should continue to engage in that community to give them the support they need, as well as seeking whatever support it is you need yourself. And once again, subsector organisations have amazed me during this pandemic. I should maybe stop being surprised at the way they can step up and help others in ways that I haven't imagined. So thank you very much. No, it's been terrific. I hope it's been helpful.
It has been much appreciated. Just to echo that point about the third sector and its ability to work across boundaries and work flexibly. So thank you for recognising that, and thank you again very much for giving up your precious time in a very busy schedule. It's been a pleasure to speak to you, and hopefully people will appreciate the guidance and the answers. Thank you.
You're very welcome, Mark. Thank you.